This conference will now be recorded.
Okay, so once again, for those of you that don't know me, you've probably all had enough of me this week. This is the last session of the week. I'm Harris, and I'm in grid training in pediatric emergency medicine, ST8, so coming to the very end of training, and I'm currently working at the Royal London Hospital. So with Selina, I've been organising this week's sessions, and the focus this week is on pediatric emergency medicine. And of course, as part of that, we couldn't leave out minor presentations. I appreciate that many of you, if you are general pediatric trainees or more junior in your training, you may not be dealing with these presentations on a daily basis. Nonetheless, I do feel, and many of my colleagues feel, that they are very useful to have known in advance. Some of you will end up working in the pediatric A&E at some point as part of your training. Some of you may choose to do grid training in pediatric emergency medicine, or you may encounter many MSK presentations through GP referrals, your clinics, or patients that come under you in ED for various reasons. So hopefully there's going to be something for everyone. This presentation is based on 5 MSK broad areas that I felt were important to cover. And there's 1 or 2 cases for each for us to discuss. I'll try to go through the initial ones quickly because we went through them on Monday and they are the more basic ones that many of you will already be familiar with. So without any further ado, let's start. So the first section I chose to focus on is pediatric fractures. There's lots and lots of things to say about pediatric fractures, but I'm gonna focus on the basics that I think we should all be aware of. And I'll start with a case scenario, very brief and very basic one. And this is a real case that I had maybe last week or the week before, but we see this day in and day out in pediatric ED. So this was an 8-year-old girl who had jumped off the sofa and landed on her left side. She was unsure whether she fell on an outstretched hand, but it was a possible push. She presented in triage with pain around her left wrist and some swelling. So the nurse in triage requested an X-ray, which was this. Any thoughts? And as I always ask, spot diagnosis from this X-ray? I have to clarify at this stage that when I say spot diagnosis, for something to be spot diagnosis, which means you're using your type 1 thinking process, that's pattern recognition, you need to have had some experience. Fiona clearly has had experience, and she says it's a buccal fracture of the distal radius, and Noella, yes, it is a fracture of the radius. So they are called torus or buccal fractures because essentially you don't see a break in the bone, like here, the traditional break that you would expect if you were looking at an older person's X-ray. Rather than that, you see the cortex kind of buckling, compressed together, giving this shape here that can sometimes appear a bit like a ring. In this case, it's milder on both sides, which is where it gets its name from. Very, very common in young children. And what do you know about these types of fractures? Feel free to unmute yourselves or just type. As I've already said, they're very common. And as I've hinted, they are not associated with interruption of the cortex. Rather, it's a compression force, which is why they're very common with push injuries, falls on stretched hand, conservative management. Yes, so there's no point operating, there's nothing to operate on, there's not much to manipulate because the compression is very mild. They do very well with just a splint. So in the past, these fractures would be casted, put in a plaster. Studies were done that showed that not only there's no need for that, but the rehabilitation and the return to normal activity, especially when it was on the dominant hand, was much better if these patients were treated with a splint that's removable rather than going through the stiffness phase that's always associated, or more usually associated, with casts. And as I've said last time, we have an RCT currently ongoing as part of Peruki network, which is looking at whether even the splint is necessary and whether these types of injuries, they're not exactly real fractures, could be managed with just nothing, watchful wait. Yeah, and that's to minimize the stiffness of the affected hand. So watch the space for the results of that study. And that leads me to a brief discussion on the specifics of pediatric fractures. Chantal, if you're the Chantal that I know, which I suppose you are, you probably know all of these. I don't know the rest of you, what background you have, but those of you that don't work or haven't worked in pediatric A&Es before looking at pediatric injuries, these may be new to you, or it may just be a refresher, which is okay. So we've already looked at one type of common pediatric fractures, and what's special about children is that their bones are much more elastic than adult bones. They have much more collagen and they are porous, which means that they are more likely to bend or buckle, compress, as we've already seen, but less likely to have a proper crack, a proper break. And their periosteum is very strong as well because they are growing bones, so less likely to break on one hand, and if they do break, they're less likely to be displaced, even if they are spiral. So we've already looked at torus fractures, and this is another picture here of a torus or buckle fracture. I'm just showing you the lateral just to see how it would look on a lateral. It almost looks ungulated, but actually that's the effect of them buckling there. So it's again a minor fracture. It's going to be obvious to some of you that this is not my patient, the 8-year-old, and I would be interested to see if people can tell how old this patient is, if you haven't heard this presentation before, because we got up to this point, I think, on Monday. How old do you think this patient is? And why is it not the same patient as the previous one I showed you? Just some thoughts. So carpal bones, absolutely. So you see a lot of empty space in the wrist here, the carpal bones. As I said last time, it's not because there's nothing there, but it's because all of the carpal bones are cartilaginous at this stage and they start to ossify, as you can see here. Whereas on the previous 8-year-old, most of her bones were pretty formed, they were just growing, so younger, and you can see much more space in between all of the bones, really, because the growth plates, the epiphyses, are still forming. You can just about see the radial epiphyses there, so a little one, yeah. And you can also see that it's taking somebody's hand to hold them down, so a few hints. Okay. Next type of fracture that we only see in children and young people is what we call a green stick fracture. And this is where, again, very, very common, this is where the cortex has broken, but it's not through and through, so the fracture hasn't made it all the way to the other side. These ones sometimes can be a little bit angulated, but not really displaced because they only affect one side. And the extent to which they go into the bone varies. Both of these types of fractures, the torus and the green stick, are very common in the distal radius and ulna. And this patient here, as you can see, the age is between the two previous ones we've seen, because even though you can see carpal bones, they are very rounded and not fully formed. So a young child, yeah, they may be, I don't know, 5. And just a reminder for those of you not currently working with injuries, bones in any way, pediatric bones have a growth plate, which is this one here, the physis, and the bone is divided in the epiphysis, which is the small part of the bone above the growth plate. It depends on the orientation of the bone, of course. Then it's the physis, then growth plate. The wide part of the bone under the growth plate is called metaphysis, and the long shaft of the bone is called diaphysis. As the growth plates fuse, you lose the epiphysis and the bone becomes one. So we're moving on to growth plate fractures. Obviously, again, characteristic of pediatric fractures, because adults don't have growth plates anymore. And what can you see here? Another spot diagnosis X-ray. I said we will start with the basics. Shout out or just type. Salter to distal radius. Absolutely, well done, Fiona. So all of these, I'm showing you fractures of the distal radius to avoid confusion and because they're so common. So Salter-Harris is the classification we use for growth plate fractures, fractures that involve the growth plate in some way. And again, I'm sure many of you will know this. For some of you, this may be bread and butter. Some of you may be digging at the back of their brain from medical school. Some of you may have done a recent general A&E if you're ST1s or orthopedics. So we all come from different backgrounds, which is why I thought that a talk on MSK, starting from the basics and then looking at some more interesting cases, would be useful. So most textbooks would use a Salter-Harris classification that goes between 1 and 5. Some authors include a 6. I felt it would be useful to include it. So, and the severity of these fractures goes up as we go up on the number. Okay, so type 1s are often missed because essentially what you have is a fracture through the growth plate that doesn't lead to much compression, but sometimes you can see it as a slight slip of the epiphysis. Very easy to miss. Some research papers, some observational studies suggest that we miss them more often than we think, but in most cases it doesn't really matter because the outcomes are good. Yeah, and the acronym S for 1, straight across. Then type 2 are by far the commonest we see, and this is the example that I showed you earlier, and this is where the fracture is on the metaphysis. Yeah, we call it above because they are traditionally shown in these diagrams in this orientation of the bone. A lot of colleagues I've worked with, a lot of junior colleagues get confused with the above and then below or the lower, which one is which. And a good way to think about it is consider which part of the bone is closest to the joint. Yeah, this is the epiphysis of the bone, therefore the joint is there. Yeah, I'll just take you back to this X-ray. Epiphysis, therefore the joint is there. Yeah, so the better outcome, as you may imagine, would be with the fractures that are more away, facing away from the joint as opposed to closer to the joint. So you can think of A as away as well. That's just something we've come up with in my department. Type 3 is below the physis. 4 is through T. So it involves metaphysis and epiphysis. Type 5, they can be serious and they can be missed because essentially what you see is compression of the growth plate, erasure or rammed growth plate. And they can't be missed because if you are not very experienced, your eyes may just be looking for a line through rather than having the experience and the ability to assess the depth of the physis. And unfortunately, these can lead to long-term complications. Even if they are recognized early, they can lead to growth arrest. So these ones definitely need referral and good follow-up. And the type 6 that, as I said, a lot of authors omit, there is a chip of the bone that includes the periosteum, and that chip needs to go through the growth plate. Otherwise, they wouldn't be Salter-Harris. They would be different types of avulsion or different types of fractures. Okay. Feel free to ask any questions at any point. I'm monitoring the chat. So back to our girlie, the one that we had, the 8-year-old with the buccal fracture. What else should you not forget to examine on this patient? Last time we had some thoughts. Some people said neurovascular assessment. And of course, that's part of any assessment you do on any fracture, any injury, elbow as well. So buccal fractures very rarely cause any neurovascular problems, but it's always good practice because there's maybe an associated fracture above. As Harry implied, the elbow is often affected. And sometimes, as you know, children can get fixated on a part of the body that causes them more pain and they can be missed. So you need to examine the elbow higher up to see for any other associated fractures. Yes, so this case is built around scaphoid. Thank you, Fiona, thank you. Look for bruises and other injuries, absolutely. So that's the idea of this. And this is a case of a scaphoid fracture. So the reason I've included that here is because it's easily missed, especially once you found your fracture. These children and young people are likely to come in saying, my wrist hurts. You examine them, you find some swelling, you find the buccal fracture on the radius or the ulna, and you think, okay, I found it. But actually, FUSH, these kinds of injuries can be associated with a scaphoid fracture, and they should not be missed. They need follow-up, and some of them need intervention. So always, always remember to examine for scaphoid. Scaphoid is this bone here. I'll show it on the real patient here. This bone here, hers is not fully developed yet, but it's pretty developed actually. It comes from the Greek word scaphos, which means boat. Apparently, some people felt that it looks a bit like a boat. And this is a fully developed scaphoid. This is an adult patient. And how can you tell this is an adult patient? You all know this, the wrist is fully developed, all of the carpals. And very importantly, you can no longer see growth plates. This is actually a young adult. All of the epiphyses have been fused. Yes, so they are more relevant to adults actually. In children, because these bones still have some cartilaginous tissue around them, they're less likely to break. But I've chosen to show you a scaphoid fracture that's not very it's not a complete one, because these are the ones we sometimes see and we can miss. Okay, so this is on the waist of the scaphoid. So this is the distal pole, this is the waist, and this is the proximal part of the scaphoid. In children, you're more likely to see a fracture in this part because the scaphoid in children starts to ossify distally and then moves proximally. So this part here is more osseous, whereas this part here tends to be more cartilaginous. In adults or in older teenagers, we see a lot of waist fractures of the waist, like here. It's very important to not miss these types of fractures, as I've said, because the way the scaphoid bone is perfused, it gets its perfusion from the radial artery, but in a retrograde manner. So the radial artery perfuses the bone distally and then proximally. So if you've got a complete fracture here, the proximal part of the scaphoid essentially can lose its perfusion. And complete fractures of the scaphoid can lead to non-union, so they often need fixation, operative fixation. I've actually seen quite a few of them in young people and young adults as part of our PEM training. Sometimes we train in adult injuries as well. You never forget those. But in children, they can be subtle. And importantly, they can be, sometimes they're not shown on the initial x-rays we do in A&E departments. Sometimes it takes a few days for those fractures to show on x-rays. So you always examine for the scaphoid. So you examine, as you may remember, many of you will, you examine the anatomical snuff box, which you can locate if you ask the patient, find a good angle, to abduct their thumb and lift it, and then you can feel the anatomical snuff box just there. So apply some pressure there, and evaluate for pain. And then this part of the thinner eminence, the bottom of it. And of course, telescoping the thumb, which you hold on to the thumb, support the hand there, and telescope, pushing. If any of these tests produces tenderness in the area of the scaphoid, these patients are suspicious for a scaphoid fracture. In some children, all you get is that, yes, there's pain everywhere. So if you have any suspicion, just follow them up, refer them to fracture clinic. Sometimes you need to do what we call scaphoid views, which is around 4 x-rays involving different orientations of the scaphoid bone to be able to pick those fractures. But again, if you do them too early on, you may miss them. So generally what we do in my department is we refer them to fracture clinic, we put them in a splint, refer them to fracture clinic, specifically mentioning on our referral that we are worried about anatomical snuffbox tenderness or scaphoid fracture, so that they have their scaphoid views x-rays when they are seen. Okay, and I'm just going to give you throughout the talk just a few easy reading resources that I've chosen. Obviously, there's lots and lots of papers, but we live in the era of blog and foam free open access, where other people have done the work for us and we can just go and read. So OrthoBullets is a great online resource for anything bone related, and they have good sections on pediatrics and good x-rays. Don't forget them bubbles, of course. I'm a fan, just like many PEM people are. And there is a good ACHEM module that takes you through soft tissue and bony injuries in children. And you can actually, you don't need to be a member. You can actually choose the parts of the module that you are interested in. So you can choose bones or soft tissue, just for a bit more learning if you're not very used to these kinds of presentations. So moving on to the Limping Child. Obviously, this would be a talk for an entire hour to go into the entire Limping Child algorithm, but I built it around 2 scenarios of 2 different ages of conditions that shouldn't be missed, the ones that I felt were the most important and common ones. So first basic scenario is a 2-year-old boy whose parents noticed that he was limping 2 days ago, but they say it was on and off, so they only come to A&E today to see you. He's otherwise systemically well, no fever. Any questions you would like to ask the family or ask me? As you would with any limping child. And what are your differentials? History of trauma, fever, trauma, ethic, absolutely. So yeah, you've all, testicles, yes. So you've all dealt, amazing. You've all dealt with limping children, obviously, because all pediatric trainees have. And these are questions that should be asked. Fascinated by the testicles, yes, that's something that is often missed in young, especially young children of this age, so spot on. ET, of course, trauma. So some hospitals, most hospitals have an algorithm or a guideline. You often see flowcharts on how to investigate and how to think around limping children. Some hospitals divide the flowchart in traumatic or non-traumatic. Some others divide it by age groups. I find the age group classifications the most useful and the most relevant ones. And of course, as quite a few of you have hinted, we need to ask for fever, look for signs of infection, because infected bones or infected joints come into the differential for all age categories. Usually we divide them in 3 age categories. I'll show you an infographic in the next couple of slides. So all good considerations. Now, this is a 2-year-old boy. What presentation do you think would be specific to a child of this age? That shouldn't be missed. Obviously, they can't tell you why they're limping. And the parents weren't even sure. They said it was on and off, so they came a bit late. They came 2 days after the limping started. So this may help you. NAI. Osteomyelitis on every child that's limping. Perthes. Perthes is one not to be missed, but generally it comes into it's higher up in the differential of the second age group, slightly older children, pre-pubertal, sort of preschool age rather than toddlers. Malignancy, so malignancy and infection is in all differentials. So yes, Jay. More specific to this age group is what you see here, which Fiona has identified, what we call toddler's fracture. Can you all see that there is a spiral fracture here on the lateral? As you can see on the AP view, it could be missed. So we always look at least 2 views of every X-ray. Yeah. So there is a fracture in the long shaft of the tibia, which you can just about see on the AP, but you may have totally missed it if you hadn't looked at the lateral view. And as I've previously mentioned, even though these are twisting fractures, quite a bit of force, it's still undisplaced because of the patient's strong periosteum, which is often the case. So we've got a case of a toddler's fracture, which is generally refers to a spiral fracture of the tibia. So, and we've already covered that. As I've said, they can be hard to see. Are you worried about this presentation and this X-ray? And what are your concerns? Anyone worried that we may be missing something, or we may need to investigate? Yes, and Chantal has already said NAI. And developmentally normal. Yes, this case was developmentally walking, absolutely. So it's a toddler. I would be worried if they were not walking at 2 years, which is why Harry has asked if they're developmentally normal. So generally in suspicious fractures of the lower limbs in children, some authors tend to divide them in 15 months, 18 months and under or above. I don't find that that's very useful. I find it's more useful to know the motor stage of the child, because some children would be walking independently at 15 months. Some others may still be cruising. So yes, this child is developmentally normal and is walking. But NAI is still a consideration, because traditionally we've associated spiral fractures with NAIs. However, the literature has shown that observations have shown that they are the commonest tibial fractures, especially in toddlers, and in most cases they're not associated with NAI. That doesn't mean that we shouldn't consider it, especially in a case like this where we have a delayed presentation, relatively delayed. So you may want to do a quick, have a quick chat with the parent, do a quick examination to see if there's any other alarming signs on the patient. And if you find anything, or a background social services check, you may want to investigate further in terms of safeguarding. But the mechanism of those fractures is quite feasible. Child running, exactly unwitnessed, and they presented a bit later. These toddlers can be jumping on the trampoline, twist and fall on the trampoline, and then sometimes they carry on jumping. So it's in many cases they are actually unwitnessed. Or toddler is running, they hear a parent calling them, they just plant their foot down and they turn around, giving that twisting force on their bone, which is enough to create a fracture like this. So in most cases they are accidental, but they do warrant a bit of thinking. And it's actually not uncommon for parents to present late, because toddlers have the ability to walk on these kinds of fractures. So you may find that they are walking on and off, which makes parents wonder, oh, should I go to A&E? Should I not go? Especially when there's a pandemic going on. So, you know, it is common. but yes, it warrants thinking and some investigation. What's also common, especially in the young toddlers, sort of the 18 months old, is that they may stop walking and they may go back to crawling. And that's actually a very good hint, because that shows you that the injuries or the pain is less likely to be on the hips or the knees of the toddler. And in those cases, always think ankle and tip fib. Okay. And then moving on to a different age group, another limping child, but this is a 13-year-old boy that's coming with acute, sharp, left-sided pain. He's not sure if it's on his hip or his knee or both, but he's coming in limping. Any questions you may want to ask him? Any thoughts, questions you want to ask me? And what are your differentials? Again, as we said, we should always consider infection and malignancy in all age groups we see. Overweight, trauma, body habitus. Okay, you all know where this is going to. BMI. Yeah, someone is gonna say now any thyroid problems. Okay, so we did an X-ray that showed this, and you all know this is actually also an MRC-PCH exam question, so it's not just for PEM people. Spot diagnosis, you all know because you've asked relevant questions. Exactly. So it's a slit upper epiphysis or capital epiphysis, and you can see it right there. As you all know, Noella, this is not pethis. Pethis appears a little bit different here on the head of the femur. I haven't included a picture of that, but the references I'm giving you do include that. And I'll show you on the part of the infographic here why I find it so useful. And most trusts actually have moved to guidelines that divide limping children in this kind of investigation algorithm in age groups. So in the toddler, sort of up to 4, where you need to consider transient synovitis, which you all do anyway, developmental dysplasia and toddler's fracture. And then pethis is more relevant in this age group. Of course, that doesn't mean you won't see it in the older child, but this is the main difference between the younger ones and this age group. And of course, conditions such as juvenile arthritis, the reactive, inflammatory autoimmune conditions. Yeah, in the older child over 10, SUFI comes into the differential. And that's because of the force, higher force, especially as you said, in overweight people. So the physis of the bone, the growth plate, is the weakest part of any bone, which is why Salter-Harris fractures are so common in children. And it's a bone of it's an area, of the bone of high activity, lots of osteoblastic and osteoclastic activity going on at all stages, while you have an open growth plate. So they're likely to either break in a Salter-Harris manner or to slip in this manner. Okay, so we've got a SUFI here. What are you going to do next for this patient? Many of you would have seen this in books, read about it when you were revising for your membership. You may have not actually treated a patient with SUFI, but these patients need orthopedic referral, and they need an urgent referral because they need surgical fixation. Okay, the rates of complication can be quite high, especially on a significantly. I'm giving you a significant slip here so that it's obvious. Yeah, even with surgical fixation, you can sometimes have complications such as impingement, especially the CAM type of impingement. That's how we call them. You may not have heard of this before. That's giving patients chronic pain, chondrolysis or osteonecrosis. So they can lead to or growth arrest. They may end up with one limb shorter than the other, even if they are operated on early, but much more so if you don't refer early or if they are missed. Interestingly, you may think of these conditions as very acute, that present in the acute phase, but actually they are very commonly chronic. So there is a slight slip that's developed over time, and the patient may present after a sporting activity that's exacerbated the pain or exacerbated the slip. So it may be acute on chronic. So they're not always acute. And apart from large body habitus, they're also associated with metabolic conditions or hypothyroidism, because it's to do with the metabolic activity in the bone. And a refresher, you use your Klein's lines to diagnose these fractures, especially in subtle slips. So you draw a line on the lateral aspect of the femoral neck, and that line should go through the epiphysis. Yeah, like in both these cases, at least a part of the epiphysis. If we draw the line on our case, the one I showed you earlier, the 13-year-old, it completely misses the epiphysis. Yeah, so that's pathognomonic. Another way is to look for the M shape that starts from the medial aspect of the neck of the femur. Follow the pelvis. You can see a nice M here, McDonald's sign, which you have lost. All good here, but here there is an interruption of this line. Yeah, it's not a smooth M. Klein's lines are pretty good. Sometimes, if you can't see anything on your AP view, you may need to do a lateral. Traditionally, we did frog leg lateral views, but just be aware that these types of fractures can be stable or unstable. So the children, the young people that come in with SUFIs and they can weight bear, they're just limping, they tend to be stable. Those that cannot limp at all, they are unstable and they can have a significant slip. And sometimes just putting them in the frog leg position can exacerbate the slip and the pain. So if you have a patient with an unstable SUFI or someone that cannot weight bear, avoid doing a frog leg lateral and just do a lateral, and you may find a slip there, or you may not need to do it at all. If you have an older teenager and you do an AP and you can't see a SUFI, but you can see that the growth plates are closed, so the epiphyses have fused, there's no point doing anything else because it's unlikely to be a SUFI if there is no epiphysis. Means they fused already. And I've already gone through this. Of course, there's a lot more to consider in a limping child, just looking at plain MSK stuff. And again, some easy reading. The slides, I'm recording this so you can catch these references. Don't forget them, bubbles, as always. There's a good podcast that also includes a blog post in the PEM playbook and a 15-minute consultation. This is a relatively recent paper in the archives that you may wish to use, especially if any of you are revising your local guidelines on the limping child. That's a good one to look at. I'll quickly move on to femoral fractures because I feel they're very important for pediatricians. Most of us have some idea, but we don't want to fall into serious traps with these ones. So this is again a real case. We had a 13-month-old boy come to A&E that was playing in the hallway of the house while the mother was cooking, keeping an eye on him, and she just heard him crying and found him crying sitting on the floor. She says he was playing with a stool at that point, and she noticed that he wasn't moving his left leg. So when we saw him, it was clear that he was in pain on the left leg, and there was swelling on his thigh, and he was very tender to touch. So we did an X-ray that showed this. Spot diagnosis. I mean, it's the title of the section, fracture. But now that we've already gone through the main types of fractures in children, what type of fracture do you think this is? Lower femur, yeah. And it's actually, you could say that it's in the metaphysis, yeah. It's just between the metaphysis and the diaphysis. So this is a green stick fracture, yeah, because there is discontinuation of the cortex, but it's not going all the way through. What will you do next? Are you going to call someone? Are you worried? So I'm guessing most of you would call the orthopedic team and put the patient in a cast. Some femoral fractures in children need manipulation under sedation or with a block, and they need to be placed in traction. These ones don't because they're not displaced, but they do need to go in a cast because they're very painful otherwise. So I guess the next question is, are you worried? Oh, have you lost? Can you not hear me? If my voice gets interrupted, I'm gonna turn my video off. It's clear to some people. I'm gonna turn my video off just to make it better for everyone. It depends on your bandwidth. Okay. So I moved to a fiber internet for today so that I don't have the same problems as I did on Monday. So I want to believe that most of you have considered safeguarding considerations. And as we hinted, as Harry mentioned earlier, we need to know what developmental stage this child is at with regards to motor development. Is this child walking independently? And when we asked the parents, actually he was still cruising. 13 months, a boy, that's acceptable. He was cruising. But he was able to independently play with the stool he was playing, holding on. If he wasn't walking at all, then obviously you are worried about this type of fracture. And of course, there are worrying features in this presentation because it is a young child with a femoral fracture, unwitnessed, no clear mechanism. He's not really walking even though he's cruising. Yeah, so needs investigation and admission. So traditionally, within safeguarding, we've known that fractures of the metaphysis of the long bones are very worrying, are very suspicious. If you have a metaphyseal fracture in the tibia, and by metaphysis, so this is at the metaphysis, but I'm more talking about what we call corner fractures, where the fracture appears somewhere there. If it's on the tibia, always be suspicious. There is some dispute in the literature at the moment as to whether they are pathognomonic. So some people avoid using the term pathognomonic for NAI because nothing really is 100% certain, but they are highly, highly suspicious, unless, of course, the toddler had previous birth injury or had treatment for talipes. On the femoral, it's not quite as clear, but if it involves the metaphysis, it's just another risk factor. And as we all know, safeguarding is about putting pieces of information together, and that's another piece of information. In the end, this child, we had a strategy meeting, child section medical, full body map. In the end, the child was discharged. It was felt to be accidental. But what if, and this is another real case that I had, what if it's a 4-month-old baby girl? So what happened? Mum was holding the baby. She had another toddler that was crying for her attention. She bent forwards to lift the toddler. I don't know why you would do that, try to lift 2 young children at the same time, and the baby toppled and slipped off her arms. And she panicked and managed to grab her from the end of the bathing grow, from the foot end. So she didn't really hit the ground somehow. But she's been unsettled since. So actually this mum came to A&E twice. On the first presentation, the colleague that saw them couldn't find anything. They did x-rays of the clavicles, they examined the upper part of the body. Mum came back later in the night because the baby was still unsettled. And at that point, we noticed that she wasn't moving her right leg as much, and we did this x-ray. And I'm sure this is clearer, and you can all see the fracture here in the mid shaft, which is actually spiral. Have I shown you the other? No, I'm only showing you one view, but it's pretty clear of the femoral shaft. In this case, we have a young child, obviously not walking at 4 months, but we've got a clear history, and mum has come in twice, and the fracture is mid-shaft. Are you worried, and what are you going to do with this one? Who thinks refer to orthopedics? Absolutely. This again needs to go in a cast, maybe traction. Are you worried with regards to safeguarding? Opinion from a radiologist? Yes, so that's again adding pieces into your jigsaw, into your Bayesian type of thinking where you add pieces of information together. Strengthening social, yes, I agree, and safeguarding should be involved, yes. So the take-home message for this one, this is one for all of us to never miss. There is a history, yes, and mum seemed genuine. Actually, mum was a social worker herself. She was working in children's social care, not the one where she belonged to, a different area. But it is nonetheless a femoral fracture on a non-mobile child, a non-walking child. So you are expected to admit this patient, get consultant review, and go through the full, consider the siblings. We already know there is a toddler. Yeah, so, and some reading, I'm not calling this easy reading because it's not really easy when it comes to child protection, but our child protection companion on the RCPCH, the Pediatric Care Online, is very, very good and has a short section on femoral fractures that essentially tells you don't miss, high level of suspicion, but through the references of that, you can go and find the systematic reviews that used to be called Cardiff core info systematic reviews, and you can read the research. What's important to say is that I've read all of them, and it's an imprecise science, really, safeguarding. So all of these guidelines we have are based on the information we have available to us so far, and we don't have any high level of evidence in these cases. And by high level, I don't mean ascites, because I don't think anyone would expect an ascit on such a condition, but even the observational studies we have, I think there is a lot more room for more robust statistical analysis, sort of multiple regression analysis, trying to really risk stratify these cases based on the factors that we can pull out from the observational studies. It's only just starting to be done now, which is why I'm including this other paper. There's lots of papers, but this Baldwin et al. Paper, I think, has a useful algorithm at the end, a suggestion for people's kind of clinical judgment, where you can put factors together, pieces of information together to help you. It's not validated, but it's an interesting read, and I hope that people that are doing research in this field may get some inspiration and do some higher level of analysis in these ones. So obviously we can talk. I left major femoral fractures and dislocated ones out of this talk because they fall more into the category of major trauma, and we're not talking major today. There is another week fully dedicated to pediatric trauma in October. I'm not sure if we will cover that, but I've purposefully left it out. I want to tell you a little bit about ankle injuries, because we do see a lot of them. If you work in A&E, you will see hundreds of them and day in, day out. But even if you cover A&E as part of your pediatric rotation, you may be referred to someone that had an inversion injury of their ankle. I can't do a full teaching on ankle injuries, but we'll just cover the basics. So a 15-year-old girl that was seen in ED after twisting her right ankle, during PE, and it was an inversion injury, as they commonly are. She came in walking to the triage room, even though she was limping. And the triage nurse noticed some swelling around the ankle. And when she was asked where the pain, the most part of her pain is, she pointed to the lateral side, sort of around the lateral malleolus. So the triage nurse calls you and asks you if she should request an X-ray. Some triage nurses will go ahead and request the X-ray straight away. Some others will ask you, what do you think? I'm very interested in your thoughts on that. I don't know how many of you have a PEM background. Can anyone just shout out or type something that would help you and decide? You may not know, which is totally okay. Yes, Harry knows. You seem to strain anterior tip fib ligament. Yeah, Ottawa positive. So, very interesting. And can they walk? If they can walk. So, you're all right in what you've typed. So just a bit of very basic anatomy refresher for those of you that are not very familiar with ankle anatomy. So when we talk about sprain, so this case was not a fracture, okay? And we didn't actually do an X-ray, and I'll tell you why in a sec. Some of you have mentioned it in the chat box. The suspicion was of a sprain, and by sprain we mean an injury to a ligament, okay? And they're generally classified in 1 to 3, 1 being just a bit of a stretch of the ligament, usually not serious, rarely any significant swelling, maybe just minor and not much bruising. Grade 2 is when there is a partial tear, and grade 3 is the more serious, where there is a complete rupture of a ligament, usually with significant swelling. And so the ankle joint is the joint between the long bones of the tip fib and the talus here on the ankle, and the calcaneum as well. So you've got on the lateral view 3 main ligaments: the anterior talofibular ligament, which is often abbreviated as ATFL. You've got the calcaneofibular ligament, the CFL, and the posterior talofibular, the PTFL. Of these 3 ligaments, as I've mentioned, most ankle injuries are inversion injuries. So this aspect of the ankle, the lateral aspect, is more likely to be injured. Of these 3 ligaments, the weakest one is the ATFL and the strongest one is the PTFL. So this ligament here is the one that's more likely to be stretched or torn. So most sprains, this area. Bless you, whoever that was. So I'm mentioning that in particular because when we say pain around the lateral malleolus, it's very important to ascertain, is it on the malleolus, on the tip? Is it anterior to it or posterior, as Harry has mentioned? On the medial side, the main ligament is the deltoid ligament. It tends to be a stronger ligament, so even medial sprains, it's uncommon to have a complete tear of that ligament. And that brings us to this decision tool, the Ottawa ankle rules that some of you know, which was designed in the 90s, initially introduced for the adult population, and there's been big diagnostic studies on these diagnostic accuracy studies that showed that it was an accurate tool to use for the adult population, and then a massive RCT with thousands of participants that showed that by using this tool, you don't have any significant complications when it comes to patient important outcomes. And this tool has actually been validated in children with good results. So when I say good results, it's got good sensitivity, so good for ruling out, not so good specificity, but it's a screening tool, okay? So if you follow this, actually, and if we all follow this when these patients come to triage, we would be avoiding a lot of X-rays, unnecessary X-rays in these patients, because X-rays mostly help us diagnose bone fractures. There are ways to diagnose some ligament injuries, but in most cases, we don't use X-rays for soft tissue problems. So And they are in two categories in both cases. So the first category is about doing x-rays of the ankle, and the second one about doing x-rays of the foot. And the reason we include foot in this type of presentation is because a lot of foot fractures occur from inversion of the ankle. So for example, I don't have much time to take you through this, and if you're not familiar with it, you're not going to remember it anyway. So next time you see a patient with an ankle injury, just have a look, maybe print it out and put it as a poster in your triage room so that your nurses are familiar with it if they're not already, so as to avoid unnecessary x-rays. So when we are talking about ankle x-rays, there needs to be pain around this area here, which we call malleolar zone. And then one more criterion, either pain on the tip of the lateral malleolus and posterior edge, and we're talking about 6 centimeters height, yeah, which is why it's important to actually examine and press on the area, because most of these patients will have pain around the malleolar zone, but their pain will be anterior. And remember, that's where your ATFL is. Okay, so those patients, especially if they're weight bearing, they don't need an x-ray. But if they're not weight bearing and there is malleolar tenderness, they need an ankle x-ray. And for this part here, I think for now it's important to remember to always examine the base of the 5th metatarsal. Again, that's a talk for another day. And very quickly, what will you tell the young person? Will you tell them, oh, it's just a sprain? Which we often do. We use the term just a sprain a lot, or just soft tissue injury. But remember, a sprain could actually be a complete rupture of the tendon. Yes, so they can take a long time to recover if they are a complete rupture. Thank you, Chantal. If they are a type 3 sprain, they do take a long time to go back to normal, but actually, if they are in grade 1 or 2, we generally advise them to go back to gentle activity. We like them to mobilize early so that they don't get stiff, and young people can have significant muscle wasting if they mobilize themselves and carry on limping, especially if they manage to get hold of some crutches. And I find from my experience, and I guess many of you may have similar experience, young people and children, when it comes to injuries, they fall in kind of two categories. There is the category of the very athletic, sporty kids that are really eager to get back to their sport and back to their game, and they are more likely to forget about your advice and just go back to their sport. So these are the ones that may need to be held back a little bit. But there's very often we have the type of patients that go in their victim mode, and they just refuse to weight bear and refuse to follow your advice. So I find that it's very important to explain to those kids that they need to mobilize. It's important to show them how to fully weight bear, putting weight first on their heel and then on their toes. And then, you know, your general price, but we generally don't do compression these days unless it's in grade 3. So rest as much as possible, elevate ice, painkillers, but carry on moving. For grade 3, they take longer, so they go through a period of immobilization. And again, we haven't got time to go through it, but there are rehabilitation-phased protocols that physios and orthopods use. And again, some easy reading. Someone is asking if I can upload the child protection companion. So if you don't have access to it through the RCPCH, I can't actually, it needs a link. So you can access it through your RCPCH membership if you are a member. Otherwise, it's available in many hospitals as a hard print. If any of you guys, because I can't navigate out of my slides now, if any of you want to give Noella the link to find it, a lot of your colleagues will have RCPCH access. Okay, so the third reading that I've put there gives you some exercise to show to people, and also a phase protocol. The important thing is that in A&E, you are not going to give all of this information to the patients, but I find that we're not very good at giving them even the basics. And sometimes even giving them some basic exercises to do is very important. For the mild sprains, we advise them to go home, and if the pain and the swelling doesn't resolve, to see their GP or come back or seek some type of assessment after about 7 days. Okay, so we are running out of time. We are actually over 3:30, and I generally like for these sessions to not overrun too much. So I'm just going to show you what cases I had for this, because thank you, Selena. So that's your link to the child protection companion, but I do think you need access rights to visit it. So this is the reason I've included this, and I'll very quickly talk you through avoiding just skipping the case scenario. It's because as pediatricians, we see a lot of these children being referred directly to us through the GP, in which case you will end up seeing them in A&E, or you may see them in your clinics, general pediatric clinics. And these tend to be young people, sort of 10 to 15, but coming with knee pain. And sometimes it can be recurrent, or sometimes it can be more acute. Any ideas? So this patient came after PE with pain, and this is a case, of course, of Osgood Schlatter. Most of you know of this, but I've included it so as to tell you about some advice to give to these patients. What is Osgood Schlatters? Essentially, in young people, it occurs mostly in young people during their growth spurt, and that's because the bones generally grow much faster than the tendons and the muscles of young people, which causes some problems in this case, because here is where your patellar tibial tendon sits. Yes, so if the bones grow very quickly, it poses a lot of tension on the muscles and on the tendons in this area, and people present with recurrent pain, especially after strenuous activity. If your young person is also sporty and they do a lot of jumping, squatting, football, that builds up their quads, but not in a way that elongates them, in a way that makes them sort of rounder, stronger, more muscly, then that's even more strain on this tendon here. And you often see the apophysis of the here in the tibial tuberosity lifted up, or in cases like this, you even see some fragmentation and some ossification. So this condition is also called apophysitis because it causes inflammation there. Okay, and what's important to tell these people is obviously eyes, rest, and all that. But the reason I've included this is because we're not very good at telling them to stretch. Stretching their hamstrings, sorry, the quads and the hamstrings is very, very important. And in the acute phase, you can ask them to avoid strenuous quad activities, and rather than do squatting, jumping, and all that stuff, they can do straight leg raises, isometric quad activities. Look them up if you haven't done a lot of sport or a lot of physio yourselves. Isometric exercises that keep strengthening while also lengthening the muscles. And then just to show you the cousin of this condition, and then I'll close it there. This is something that not many of us have been taught about in medical school, but we do see it a lot. So with the Osgood Schlatter, the pain tends to be sort of there in the tibial tuberosity area. In this condition, you have pain involving the inferior pole of the kneecap, of the patella. And this is, anyone knows what this is called? Triple barrel Sinding-Larsen-Johansson syndrome. Yeah, so it's very similar, but in this case, the apophysitis is more on this side. Treated very similarly. And again, don't forget to recommend these patients to do their stretching. Some of them may need referral to physio, but in most cases, by showing them some exercises, not much follow-up is needed. And these are some cases that we tend to just brush off. We say, oh yes, this is common. But again, I find, having worked with some physios through my PEM training, I find that they're much better, and some ENPs in A&E, they're much better at giving this kind of advice to the young people than we are. And some reading around that. Radiopedia is a very good website if you want to see good x-rays, and I've used some of their x-rays through there. So we're only 8 minutes over time. Sorry, I had to rush through the last section of the talk. But as I said, it's one of the things I've learned in my training, and I just felt that just giving some of you some basics of common, minor, but very important, and very important to the young person and to the child, advice and tips about these presentations would be useful, especially those of you that are about to embark on PEM post. Feedback link. Thank you all for being here on a Friday afternoon. Apologies again about the problems we had on Monday, but at least we made it this time. Feedback from, thank you, Selena. And the learning pack has been shared and reshared many, many times before. So thank you all for being here. Are there any questions? I'll let those of you that need to rush off and do some work or enjoy your nice Friday afternoon. If there's any questions, I'll be happy to take them before I stop the recording. So this actually concludes the PEM week. So most of you have had enough of hearing my voice. I was actually at a social distancing event yesterday, pediatric event, and a person approached me and said, oh, I recognize your voice and your accent. You've been on a lot this week. So yeah, so it's a small world. Okay, so I'll stop the recording and let you all off.